After all these decades, there is still scope for improvement. The ideal bleb where we want the filtering bleb to be diffuse, low-lying, relatively avascular, and having a polycystic appearance eludes a lot of us, especially over a period of time. The glaucoma surgery has had modifications so that we can deal with the wound healing process that takes place after the trabeculectomy. So there has been the use of antimetabolites. The surgical steps have also been modified to a great extent, and also space occupying wound modulators like the collagen implants have been used, primarily in a bid to have a bleb which has a long success period, a better predictability, a good IOP control, and avoid serious complications of bleb leak and thin cystic blebs in the long run. So one of the new modalities that is being used nowadays is the amniotic membrane. The membrane is available easily and has been used lately in wound modulation of trabeculectomy, primarily because the amniotic membrane is anti-inflammatory, anti-fibrogenic, anti-angiogenesis, antimicrobial, lacks immunogenicity, and is easily available. The amniotic membrane is being used to augment the wound healing process, both by being an anatomical barrier, whereby it is keeping potentially adhesive surfaces apart, as well as being a biological barrier, where it is down-regulating TGF-beta and suppressing the fibroblastic and macrophage responses. On the whole, it has been found that it has improved the appearance of blebs and improved the longevity of the bleb. It's available in either a dry or a wet form. Both are recorded to have been used in amniotic, in the trabeculectomy. These membranes have been tested for viral markers and are relatively inexpensive. It's easily incorporated in the routine surgical technique that the surgeon is using, and it does not really have much of a learning curve. So it's perfectly possible to use it both in limbus-based or fornix-based surgeries. The membrane is usually applied over the ocular surface after the scleral sutures have been applied, though in refractory glaucomas or in repeat trabs, some people have also used it partly subscleral and partly subconjunctival. The watertight closure is recommended. We've used both the dry and the wet forms of the amniotic membrane and find that the wet form adheres better to the ocular surface, and even in the post-operative period maintains better bleb appearance. On occasion, the dry form has been found to probably get rolled up, so the blebs were a little irregular or high. It can be done both as a primary procedure as well as in addition with mitomycin C. Anchoring sutures are usually not really required. When we look through the literature, we see that amniotic membrane has improved the success rate. In one of these studies which was done at Guru Nanak, it actually improved the absolute success rate from 60 to 80%. And though some other reviews show that the IOP control may not be markedly different between the whether we use Trab with MMC or Trab with MMC plus AMT, what it does make a difference in is that the architecture of the bleb is much better. In fact, a newer study has also shown the ultrasound biomicroscopy report of the blebs, and it has found that the percentage of diffusely elevated blebs is much better, and the overlying conjunctiva is healthier. On the whole, even fewer post-op interventions have been found. So in refractory glaucomas or in repeat,
इसमें नहीं आ रहा भैया, स्लाइड नहीं आ रहा है।
आपके वहाँ से इधर पे आ रहा है. So basically when we have a refractory glaucoma, they recommend that this area of membrane cover should be larger, and one could combine using it both subsclerally and subconjunctivally. So in our center, we've been using the amniotic membrane along with mitomycin C to augment trabeculectomy, and we've done it for about 2 years now. A significant number of cases have been done, about 100. We took out about 30 that were primary open angle and as a primary surgery, which did not have any additional risk factors. And the pre-op IOP was on an average, the mean was 27.76 plus minus 6.9. And the post-op at 1 month was 11.9 plus minus 4.8. And at 1 year, it was 15.28 plus minus 4.25. 4 of these were on 1 anti-glaucoma medications at 6 months, and 2 of them were on 2 medications at 1 year. We had an incidence of shallow anterior chamber in 2 patients in the first week, which resolved on conservative management within a week. And 1 case had hypotony maculopathy, which also recovered in 6 weeks with good visual prognosis. So it does have promising trend in case in patients of trabeculectomy, where AMT can be used as an additional wound modulator in addition to the use of mitomycin C. We have not really done it in patients without mitomycin C, and it is a tool that can be used as an armamentarium. Thank you.
Thank you, Dr. JASLEEN, for saving time, but we are so disturbed because the audiovisual didn't work and we missed a lot of audiovisual things for you. Thank you very much. Can I?
Now the next speaker for the talk is